Welcome to Variations 4, our respiratory unit. In this video, we will cover questions 1 to 3. Our main focus will be pneumothorax and tension pneumothorax. So question number 1, answer in one sentence what the main problem with pneumo and hemothorax is. Simply blood or air in the pleural space, causing lung tissue to collapse. Let's take a picture, a look at the picture, which makes this much more clear. If we move to your PowerPoints, then we can see very nicely here in illustration what was just said. So healthy lung tissue, alveoli, etc. Pleural lining, that's that twin membranes, two membranes with a little bit amount of fluid in between to create a negative kind of pressure. That's what a healthy pleural lining should look like around lung tissue. Here, you can see the pleural lining has been vastly stretched by way of filling with air, well, in this case, air, but it could have been fluid too. It could have been blood, exudate, pus with some kind of infectious process. Anything can stretch this pleural lining, air or fluid. The problem if air or fluid stretches the pleural like this is it presses up against soft lung tissue, which can't compete with these pressures and is unable to expand. What kind of compensatory mechanisms would you expect the body to put forth? Think specifically neuro, respiratory, and cardiovascular in this case. Well, since this lung tissue can't expand, we've obviously got compromised ventilation here, or the ability for gas exchange. We're going to see neural deficits related to decreased oxygenation of the brain. We're going to see respiratory compensations, such as increased resp rate, shallow resps. This may be painful. We're going to see cardiovascular changes, such as potentially early on an increase in blood pressure, fight or flight, an increase in heart rate. As this gets worse and worse and we move towards a tension pneumothorax, we'll see some of those vital signs change. We'll get to that in a minute. Question 2 asks about open or closed pneumothorax. In this case, we have an open pneumothorax. Some kind of stab wound is allowing air to enter from the outside and fill the pleura. Easy to come in, very difficult to evacuate this air out of the pleura unless we have some medical intervention. You could also get a rib fracture internally that could puncture the pleura and cause bleeding and exudate from the inside that could cause this to fill. We also talk a little bit about blebs that are sometimes on the outside of the pleura. Not sure what causes these small air pockets, but they can spontaneously revert or turn the air internal into the pleura, causing it to expand because of air. This typically happens to tall, thin people, statistically. So if we just take a look at the maps here, not a whole lot of new things said. It's just what I've said in word form and in graphical form. So feel free to peruse that. You've got your triangle here, which kind of we've already talked about symptoms. Then, of course, the circle, which is what do we do about this? How do we diagnose it? You've got some imaging. You've got thoracentesis and chest tubes, which we'll talk about in a bit. And of course, analgesics are huge because first of all, the trauma itself or the pneumonia or whatever's caused the pleura to fill, that specific event could be painful in itself. Not to mention that when we throw a chest tube in there, pain with inspiration increases more. So pain management around patients with chest tubes is huge. The third question asks us to discuss tension pneumothorax. Let's look at the picture first here. So if we take what we were talking about earlier with air filling here and just let it keep filling, don't intervene, what's going to happen? What's going to happen is the pleural space will continue to press on this tissue, eventually pushing against organs and things like the trachea in the middle of the chest here, the mediastinum, and it can cause, visually, you'll see the trachea deviate to the opposite side from the pressure. These major vessels here are also going to start being compressed, the vena cava and the aorta. What do you think is going to happen to vital signs in this case, this tension pneumothorax? Pressure against these great vessels is going to cause cardiac output to drop. That's going to drop blood pressure. But early on, everything else is going to rise. Fight or flight, rest rate goes up, heart rate goes up, but it won't last long in tension pneumothorax. With that drop in blood pressure, eventually oxygen is going to be seriously deprived to organs, and your patient will die if we don't intervene. Just looking back at the maps here, if you look at tension pneumothorax, there's not a whole lot that's added to what I just said.